Welcome everyone to our first OB tutoring. My name is Blake and I'll be your SI instructor for the duration of the semester. If you can go and do your attendance, that'd be great. Go and pause the YouTube link right there and just going to finish that up. All right, let's go on to the next slide. So we have the Allie who was before me. She did a great job on this stuff. I just edited it and add my own stuff to it. This right here is going to be how you can go and contact me this semester. We do have my email. I ask that if you're emailing me, just so I don't get like spam or anything, can you guys go ahead and just do, OB tutoring, first name, last name, and, you can be informal. You don't have to do the whole thing like good morning, stuff like that. You can just say, hey. I'm also giving you guys my phone number. If there's any questions or like something's coming up or really just anything, you can always reach out to me. And then, like I said right here, I'm going to be posting everything on y'all's Facebook page. So it'll be really easy to find. Just right away, I know everyone would love to really do really well in this class. That's kind of the goal, right? But just little tips from here. From me, I would recommend to go and listen to these SI sessions. It'll really help a lot. If there's anything like personal stories that Professor Harrell does, go ahead and mention. Those are really good as well. Later down in the semester, she's actually going to give you guys like extra credit assignments. And although, if you're doing really well in the class already, I still recommend to do those things because it just helps. It's always going to be content based. It's not a waste of time. Even like we're going to have like crossword puzzles. We're going to have blueprints, stuff like that, just to help you guys along the way. On this PowerPoint, we do have stuff that's highlighted. I would highly recommend just to pay attention to that as well. And what I did when I was in this class was I would go to the SI sessions, either live or later recorded. I would type all of it up, and then I would actually merge that with my notes from Professor Harrell's class. And also just relax. I guarantee you guys, you're smarter than you think you are, and you're going to do really well. Alrighty, starting off with genetics. This is kind of just in the first day of class. It's not going to get too in depth. Right away, we have the difference between mitosis and meiosis. And I always like to think of meiosis as our parents made, well, if you're talking for yourself, me, so that is going to be our sex cells right there. Mitosis is going to be the other one, of which the mother cell produces two daughter cells, and each is going to have their own genetic makeup as the original cell. This makes growth and development possible for those things in the somatic cells. With meiosis, it's going to be the sperm and the ova. This is the process of which cell division occurs, with diploid cells giving rise to the haploid gametes. And this stuff, guys, I know it's really confusing right here, but really just, if it's too hard, just go and read the book a little bit more. A lot of this stuff, it's not going to be like fun in depth with all these hard terms for your tests. We're just getting a really short overview for things we're going into. And then our humans are going to have 46 chromosomes, 22 pairs of autosomes, and 1 pair of sex chromosomes. And the spermatogenesis is going to result in 2 times the spermatids and 2 Y spermatids. Our oogenesis results in 1 ovum. And then, of course, when it comes to these chromosomes, the males are going to have XY and the females are going to have XX. And always remember right here, the male is what determines the sex of the child. Going into the phases of the menstrual cycle, this, she just really wants you to get a good overview. If you can kind of process this a little bit with the maybe like your hormones and stuff like that, it's going to help a lot. So of course, our menstrual cycle is going to be a 28-day cycle, normally, if not impacted by like birth control, things like that. And it's important to know that this cycle is going to begin with the menstrual phase. It's not going to end with that. So as long as you know where it starts, you should be good. Ovulation is the time whenever the egg is actually going to be released. And this should be around 14 days after our start, okay? And then going into these with number 1, the menstrual phase is from days 1 to day 5. This is when we're having that actual bleeding that marks our start. The second is going to be the proliferative phase. This is going to be day 5 to ovulation. And LH, which is the luteinizing hormone, converts the follicle to a corpus luteum. This is going to produce progesterone. And then progesterone is actually going to be our pro-pregnancy hormone, but we'll learn about that more today. Number 3, we have our secretory luteal phase. This is going to be from ovulation to about 3 days before our menstrual cycle. And during this, our estrogen levels are going to fall and the progesterone levels are going to increase to support our possible pregnancy. So it's all pro-pregnancy, and it's just trying to get that ready. Next is going to be our ischemic phase. And this is going to be about 3 days before our menstruation to the onset of menstruation. If fertilization has occurred, the corpus luteum will degenerate, kind of really getting that ready. I'm sorry, if it did not occur, it's not needed. So that's whenever we're going to go right back into our menstrual phase and begin with that bleeding. And this is also going to be where our estrogen and progesterone levels are going to drop. Really with progesterone, there's another thing to mention. After a few miscarriages, these are those levels that are going to be checked regularly, because if at all that pregnancy is not going through, this could be an error with that. These patients could be given shots to promote the pregnancy, decreasing the risk for miscarriages. Going into ovulation, this is going to be really important stuff here, and I actually did highlight that for you guys. This could be really good information for like a sucked that all apply question. So going into it, it's going to be whenever our ovum leaves the ovary and enters the fallopian tube for fertilization within the ampulla. And that ampulla is actually going to be the upper third of our uterus, okay? This is going to be 14 days before our next period. So really just getting that pregnancy ready. We do have a few signs here, and the big 3 are actually going to be what's happening in our cervix, what's going on with our mucus, and then also our raising of our basal body temperature. But right off the bat here, we have the temperature is going to increase about 1 degree. And our mucus is actually going to be thin and stretchable, and this is actually called spin bark heat. That's a really important term. That's why I went ahead and bolded that for you guys. This is, and I'll show a picture right after this of what that kind of looks like. With our cervix, it's going to open up a little bit, and it's going to be able to kind of just allow for the sperm to pass through. With our hormones, the estrogen levels are going to fall, and our follicle stimulating hormone is actually going to increase. We also have another term called the middle smirts, and this is actually where there's going to be pain on one side of our abdomen. This is because only, although the eggs are produced on both ovaries, it's only going to be released by one side. And right away here, we do have what's called the spin bark heat. On the left, you can see it's very thick, not really allowing passage. But on the right, we do have when it's very thin and really stretchy as well. This is kind of a graph here, if you're more of a visual learner. So I'll go ahead and feel free to pause there if you're looking at the recording. And our next topic is going to be fertilization. A little more in here, we do have kind of the difference between our sperm and our egg is that the sperm is going to be most fertile for about 24 hours. But of course, it can still fertilize that egg after up to 72 hours. And this is really good. I know that in your homework, it's going to be like questions about stuff like this. With our egg, the ova, it's going to be only viable for about 24 hours. And this is really important because if, let's say, someone does have sex, unprotected sex, and the next day they begin to ovulate, they can get pregnant. Eggs come up through the fimbriae. The zygote is the initial cell formed after that sperm and egg have joined. And again, with our ampulla, this takes place in the ampulla in the outer third section of our fallopian tube. This is going to be around 3 days to the zygote, where it moves through the fallopian tube towards our uterus. And this is all kind of going actually with our cilia. So if this isn't really like, there can be some things that actually make this a little bit harder. Some things like smoking, diabetes, things like hypertension, sexual transmitted diseases, things like that. So anything that causes damage to our our body, our lungs, will affect that cilia, affecting that transition towards where it's going to be implants and things like that. And that actually can lead to what's called an ectopic pregnancy. And you'll learn more about that this semester. An ectopic pregnancy is going to be where if an egg doesn't really move to the uterus, then we're actually going to go ahead and do a D&C, which is kind of an abortion because there could be a risk of mom damaging her uterus, things like that. Big things to take from this are going to be our ampulla, and females are born with all of the eggs that they will ever going to have. That's why later in life we get towards like menopause, things like that. And then of course our males are going to be able to continuously make sperm and never run out. We do have our implantation, also called nidation. I don't really think that's going to be on anything that you're going to have, so don't really stress about that. That's just another word. Kind of going off here, we do have the trophoblast is going to attach to our endometrium for further nourishment. And the best site for this implantation is the upper 1/3 of our uterus. Going to our hormones, going back to that upper third, if you ask, why, this is because up there it's more vascular, it's going to be able to create a stronger placenta and overall produce a healthier baby. With progesterone, this is going to be high because progesterone prepares that endometrium for our pregnancy. Remember, pro-pregnancy. And as an example, suppose you're implanting in the upper part of the uterus. It's more vascular. This is able to really just provide increased blood flow and nutrients towards our placenta. And if it's at all implanted low, we do have more chances for bleeding, things like that. The blastocyst is also going to implant 7 to 9 days after fertilization. It's then going to sink into our uterine lining until it's completely covered. We do have the placenta right here, and really just going on to it, you see all these vessels here. It's important to note that we do have our 2 arteries and 1 vein right there. And then there's also going to be a video on Blackboard, not Blackboard, but if she's giving it to you, but it's actually through Khan Academy, and it's going to help really a lot with learning about our placenta and things like that. Going into our anatomy of our placenta, we have 2 sides here. We're going to have our amnion and our chorion. The chorion is actually going to be our fetal side, and we're actually going to show you some pictures in a little bit. But with our anatomy, placenta is going to be very important for our baby. And this is also a reason why some women might have some complications. All of these vessels here, this is a highly vascular area. And if something is going to go wrong with our placenta, we could have our mother bleed out and die. Also, as well, our placenta is going to be really providing oxygen to our baby. Their lungs aren't working yet, things like that. So if we do have any problems with this, we're also going to have perfusion problems, and that's just not really that good. Kind of think of it as like a water hose. If you were to like squeeze it, like a kink rather, that could be the same thing with our placenta. Going in here, we have 2 sides. I'm pretty sure Harold might have showed you this already. We have 2 portions. We have the maternal portion, the decidua basalis. I always remember it by just the Dirty Duncan. And then we also have our fetal portion, the chorionic villi. That's going to be the shiny Schultz. A few things of our placenta here, highlighted for you perfectly. We have our that they exchange nutrients and waste products. They're going to produce our human placental lactogen, estrogen, and our progesterone hormones. This is also going to provide our fetal respirations as their lungs aren't working yet. And then during the 3rd trimester, they're going to transfer antibodies, providing the fetus with passive immunity. Really important note here that are with the placenta, large particles, bacteria cannot pass, but things like nutrients, medications, alcohol, antibodies, and viruses can pass through the placenta. So you might be tested later on things like what could pass, what type of vaccines and stuff do you not want to be getting during certain portions of pregnancy, things like that. some keynotes here, like if our mom has hypertension, then the placenta just will not really get enough oxygen, affecting our O2 levels. If we have a mother that's undernourished or diabetic, this can really also affect our placenta. It's all about forming the best kind of home for our baby here. If there's no blood going to the placenta, then there's going to be no blood actually going to our placenta when the mom is contracting. So a lot of times you will see this during our fetal heart monitor. You're going to see, their heart rate kind of associated with that as well. All right, keep going. This is the other side of our placenta right here. We have the fetal portion. This is called the shiny Schultz, chorionic villi rather. And some of the things that we would like is we don't want to have any knots in the cord. We also want to make sure we have a long enough cord. And this entire thing right here should be really plump. It's going to be filled with Wharton's jelly. And the Wharton's jelly comes into play later because whenever this actually gets exposed to oxygen, a lot of the Wharton's jelly is going to constrict. And that's actually what actually cuts off the fetal circulation, because then we're going into the babies being able to breathe themselves, things like that. We have our amnion here, and this is really because when we're having a mother say, "Oh, my water broke," this is actually what's happening. The amniotic sac is actually kind of bursting, rather. Really important stuff here with our amniotic fluid. We do have just the overall concept of this. It's going to act as a cushion. It's going to protect against mechanical injury. This is also going to help control our fetus body temperature. This is going to provide adherence of the amnion. This is going to allow freedom of movement. This is also going to permit symmetric growth of our embryo. And this is going to contain our fetal urine and measure for kidney function. And we actually could have some problems within the early and later stages of development. So if there is like low amniotic fluid, this is kind of, we could have things like Potter syndrome. It's kind of hard to fix. We're going to have decreased oxygen to our kidneys, and just overall not being a good thing right there. If we have a high amniotic fluid, then we're going to have some swallowing issues, some other defects around the mouth. Man, I think that's pretty much it. With amniotic fluid, our early problems could be poor muscle development and webbing, and later problems could be movement trouble and cord compression. And if you're wondering how this kind of measures kidney function, at around 8 to 10 weeks, our babies are going to be actually excreting fluid. This is going to become our amniotic fluid. And when we have low amounts of volume, this is going to be called oligohydramnios. I can type it here for you. Really hard to pronounce. There. All right, moving forward. We have our chorion right here. This is going to be the outer membrane of our amniotic cavity. This is going to be forming our fetal part of our placenta. And this is the site of testing. It's going to be more on that later when it comes to our genetic testing and things like that. We have 3 trimesters. The first is going to be 1 to 12 weeks. The second is going to be 13 through 24. And our third trimester is going to be 25 through 40. Going into a little bit more hormones here. We're always going to keep giving this to you, things about progesterone and things like that. We have our placenta endocrine function. So like I said, this does go ahead and produce our hormones for us. We have HCG. This is going to be our human chorionic gonadotropin. This is kind of our pregnancy hormone. So whenever we actually have that test, this is what's kind of in there, what it's really looking for, okay? This is also going to be the hormone that's really associated with like our morning sickness, things like that with pregnancy. We have the HCS hormone, also known as HPL, the human placental lactogen. This is really important when it comes to things like, getting that mother ready for that stuff, for lactating, things like that. And we also have relaxin. This is going to be more along the lines of really getting that body ready. This could be things with like our love handles, things like that. Then we're also going to have our steroid hormones, estrogen and progesterone. And it's really important to know these functions, okay? Let me go and see if there's any notes that I'm missing from here. With our HCG hormone, this is going to be present in our blood 10 days after fertilization. So let's say you have someone that has unprotected sex, and the next day they go and take a pregnancy test. It's not going to show up, like I said, until about 10 days later. With our HPL on that second bullet there, you could add to your notes that this is really important to monitor for our diabetes patients, because this may increase their need for some more insulin right there. And then with relaxin, this is going to be all about our uterus right here. If you have relaxin at an early stage where it's really not needed yet, this could lead to uterine contractions and maybe things like early pregnancy, things like that. And then progesterone is going to be important for when it comes to maintaining our hormone levels throughout pregnancy. Like I said, if our mother's having a history of spontaneous abortions, things like that, this is really important to kind of monitor as well. We might have to give them some extra help with like shots and things like that. That's it. That's why I was confused. I have it all right here. HCG, really important for nausea and vomiting, more morning sickness, and this is that hormone for that. If these values are actually falling early, then there's nothing to stimulate our estrogen and progesterone, leading to our spontaneous abortion. So really in the early stages of pregnancy, this value right here is going to just be increasing and increasing nonstop. And it says right here in my notes, HCG stimulates progesterone and estrogen secretion by the corpus luteum until the placenta is formed and functioning. These levels will double every 48 to 72 hours, peaking at around 60 through 80 days, and then slowly going to decrease between 100 and 130 days post-conception. HCS, it's important to know that blood sugar does increase in mom. So this is important to kind of monitor with our diabetes patients. HCS really comes down to breastfeeding. Like I said, it's also called the human placental lactogen hormone. This is going to increase insulin resistance in the maternal tissues. This is also going to provide glucose for our fetal growth and development. Relaxin is going to be helping our joints in our uterus. Really just relaxing. This is also going to come down to like more funds terms as well. With when the body is relaxing, one of the things that can also occur is constipation. And then you do not want to have mom having contractions until our baby is done cooking. Okay. With estrogen, it's going to have proliferative function of our uterus, breast, and breast tissues. This is going to increase vascularity. And this is good because we need to be really having increased blood flow, increased nutrients, really just making the size of our uterus as well. This is actually going to be one of those hormones is actually really included with birth control. And this is usually going to be estrogen or progesterone. This is actually the values that make your body think that it's pregnant, so you're not having those periods, okay? This is also going to be love handles, breast enlargement, things like that. With progesterone, we have pro-pregnancy. This is going to increase secretions of in our fallopian tube and uterus to provide really just adequate nutrition matter for the morula and blastocysts. Those terms, I really don't think that's too heavily tested on. This is going to be lowering our contractility of our uterus, keeping the baby in there. This is actually going to be called causing amenorrhea. So that's going to be called no period. And really just remember that progesterone is actually maintaining everything, which is pregnancy. And this is going to help prepare our breast for lactation. Progesterone is also going to be secreted by the corpus luteum. It's going to peak 8 days after ovulation, the same time our implantation occurs. And then with these levels of progesterone, 10 weeks within the pregnancy, so kind of nearing the end of the first trimester, the placenta is actually going to take over production. With our prostaglandins, this is really important right here. Later down the line, you're going to have like medications that actually are prostaglandins because right here, as you see, this kind of actually induces our labor. If at all we need to have like a clinical abortion, this is actually what we can use as well. Kind of simply put, this is going to make everything contract and it's going to get things kind of moving, get them out, things like that. This could cause diarrhea. Our bowels are going to contract, and because a lot of our smooth muscle contracting, this is what's kind of causing diarrhea. And the medication that's going to be associated with this is actually called Pitocin. That's how you spell it. Next, we're going to be going into fetal circulation. Here we do have, kind of showed you that picture earlier. The really important thing to take away is going to be that the arteries and veins kind of switch roles from ourselves. We're going to have 2 arteries and 1 vein, and that our veins are going to deliver the oxygen towards the baby, and our arteries are going to take it away from the baby towards our placenta. Right here, we do have our fetal heart rate. This is going to be around 160 to 170 beats per minute during our first trimester. It's going to slow down as the fetal growth occurs, kind of going down to about 110 to 160. And this number is usually going to be twice our maternal heart rate. That's a good way to remember that, okay? This slide here might look like a lot, but I have made a slide right after here to kind of summarize it really good for you. It's important to know that this is going to be our baby right here on the right side. That within fetal circulation, the lungs do not function. The placenta is going to be doing all the work right here. And we have a whole special system that makes it for our blood and oxygen to go and bypass our lungs, okay? We're going to have the umbilical vein that's going to go towards our ductus venosa, kind of bypassing our liver, going to the inferior vena cava. Within the kind of middle right here, within the heart, we're going to have what's called the foramen ovale. That's going from the right atrium towards the left atrium, to the left ventricle, then towards the aorta. Then we're also going to have, kind of as a summary here, we have our right atrium from the superior vena cava. That's going to be having deoxygenated blood towards our tricuspid valve, with our right ventricle and our pulmonary artery. This is going to pass through the ductus arteriosus, descending aorta towards back to the placenta here. This slide here is really only put for those that really want to know the details. It's going to be a lot more simple than this on your exams and things like that. And that's why I provided this slide in a little bit, okay? Okay, the slide's actually right after this one, never mind. Within fetal circulation, we have blood returning from our head to our upper extremities through the superior vena cava towards our right atrium, then our right ventricle to the pulmonary artery, and a small amount to the lungs through the hepatic portal. It's important to note that our large portion of our ductus arteriosus is going to go into our descending aorta, and it's going to return through the 2 umbilical arteries. So what I would really do for this is kind of put it all into our notes, whether it be on a Google Doc or a Word doc, or if you're handwriting it, whatever you would like, and just really break it down through there. And if going to kind of wrap this up and do something that's a lot easier, we have it all right here. And I went ahead and this can be found on actually it's going to be on our, you can find it on YouTube with a, like as a little example. But to kind of really break this down, we're going to have on the bottom left here, the umbilical vein that's going to be carrying oxygenated blood towards our fetus. Located right here, kind of in purple, we're going to have our ductus venosus that's going to be connecting the umbilical vein and the inferior vena cava, bypassing our liver. Then located in the heart, we're going to have the foramen ovale, which is the opening between the right and left atria of the heart, bypassing our lungs. And the reason that's going to be happening is because while the baby is actually in utero, we have so much pressure kind of built up within our placenta in our lungs. So the oxygen actually can't even go there. It's just kind of what happens here. Then lastly, we're going to have the ductus arteriosus, and this is going to connect our pulmonary artery to the aorta, bypassing the lungs as well. So the really easy way to kind of think about this is if you just write it out on top of each other. You have on the top the ductus arteriosus, then you have the foramen ovale, then right underneath that you have the ductus venosus. And of course, if you're trying to memorize a certain way as well, V is kind of later in the alphabet, so it's gonna be lower down. And then next to that, of course, we're gonna have vein with our umbilical vein kind of going towards our fetus. And this is all occurring because our lungs actually are not functioning. That's kind of what's happening. And then kind of later down the line, this is just really good to know. This entire process must close after birth to allow blood flow through our lungs and our liver. Going into fetal development, within the first 2 weeks, this is actually going to be called our pre-embryonic stage, the stage of the ovum. And this can be a stage of that our malformations can occur, resulting in our viable fetus. During the first 3 to 8 weeks, it's going to be our embryonic stage. And this is going to be where at the end of the 8th week, every single, most of our organ systems are going to be formed, and the remainder of our gestation is actually going to be devoted to refining these organs. That's why if you have like a mother who's maybe not aware that she's pregnant, and during that 7th, 8th week, she's doing some activities that are really altering these things, that's where you could have some issues right there. Conception is usually going to occur around 2 weeks into your pregnancy. This is going to be where your body prepares a spot for your baby to grow and nourish there. So it's going to be growing a layer of rich tissues for that. Between 2 to 11 weeks, our baby's actually going to be called an embryo. This is when the develop is going to be going there. It's going to be a busy few weeks for that stuff in the first 2 to 11 weeks. This is when our baby's brain, their spinal cord, and all of our organs are going to be formed. Alrighty. Between 11 and 28 weeks, this is going to be what's called fetal development. This is going to be where we're actually called the fetus now, and it's going to take on a whole different meaning, and I'll kind of go into a slide after this. And then if you want to write down as well, like if you're listening to the recording, from 29 to 40 weeks, the baby is going to be focusing on lung development. This is really vital to complete. That's why if we have, a baby that's born premature and that those lungs are not prepared, we could have some issues right there. And this can all be found kind of on this next slide that we're looking over. And I'm gonna click it right now. We have some milestones here. This is really, really important stuff. I know that Harold might have shown you a slide and it might have had like large varieties of numbers. But really, just if you think about it in the way of this slide right here, this can kind of help a lot. And this can be really your good foundation for everything moving forward. If you can memorize this, it'll help a lot when it comes to genetic testing, things like that, or just kind of, when you're looking at a problem and it's telling you how old your baby is, if you can just picture what's happening right there, that'll help a lot for your exams. Kind of highlighted in blue here, really important stuff. We have at 16 weeks when our baby's sex can be seen. At 20 weeks is whenever we can actually hear the heartbeat with a fetoscope. The mother can also feel the movement, which is called quickening. At 24 weeks is viability because our respirations are going to begin. This can be, once you kind of learn more about like premature birth, things like that, this makes a lot of sense because you're just kind of knowing, what's going on, and viability is really important. At 28 weeks, this is when our baby can breathe, although this is when surfactant will be needed. So surfactant is something we can actually give towards our baby if they're kind of needing that extra boost. Let's say they're born premature and we know they're coming, we can actually go and give them surfactant, things like that, through steroids to kind of boost that production. At 36 weeks, that's when our lungs will finally be mature and surfactant will be present, okay? Kind of going into the next slide, this is really important. And it makes a lot of sense for me because I'm a twin. My brother is, we're fraternal twins, so we would actually be what's called the dizygotic. So with this, we have a double ovulation resulting in 2 eggs. We're going to have 2 placentas. Sometimes they might look like one together. We're going to have 2 chorions, 2 amnions, and twins can increase with parity. And then I went ahead and typed in there for us, layman's terms, this is fraternal twins. With monozygotic, this is going to be things that produce siblings who are the same sex and genotype, so they're really looking similar. This is going to be where 1 egg divides into 2 separate zygotes. And this can be where we're having 1 ovum. This is going to be identical twins, things like that. And then with these type of twins, we could have some little issues. We can have some complications like TTTS, which is kind of where they could be conjoining, or whenever our blood is kind of moving from one twin to the other, and one is kind of being left out while the other one is getting so much blood. This is where we can kind of have that. And as some notes on the side, we have our chorion. This is the fetal membrane, is going to be closest to the intrauterine wall. This will give rise to our placenta and continue as the outer membrane is surrounding the amnion. Some notes to put on your amnion. This is the inner of our 2 membranes that form the sac containing our fetus and our amniotic fluid. So amnion, amniotic fluid AF. And kind of going into that, what is our baby floating in? This would be amniotic fluid. So really just bring that together. That's why it's the amnion closest to it. Kind of some things to take away from this as a summary would be that dizygotic would be the safest. We're having 2 placentas, 2 babies, things like that. And yeah. Does anyone need a break real fast? Do y'all need a little break? Alrighty, we'll just keep going then. Going into genetics, we have some stuff. I don't have any highlighting on here. This is just really important for you to know, but the questions shouldn't be too hard with this stuff. Just pay attention to her notes, pay attention to this, and you should be okay. We do have autosomal recessive genes. This is going to be expressed only if it's homozygous, the inherited gene. When this is actually paired with a dominant normal gene, it's not going to be expressed. It'll be through our genotype, but not the phenotype, which is our appearance. And this, as an example, this would be PKU, Tay-Sachs, and cystic fibrosis. Kind of as an example here, and this is kind of going back to like high school biology with the Punnett square. If you have one parent that's carrying the gene, the baby will not have it. If both parents are carrying it, then there's our kind of differences here, where we're going to have 25% of it being normal for the affected baby, 25% affected, and then we could have 50% of where they're going to be a carrier, because you notice they do have that recessive in there, but the dominant is taking over. With two lowercase, it's going to be actually gonna being expressed there, but if it's too dominant, it's going to be not really being expressed because this is an autosomal recessive gene. With genetics, we have an X-linked recessive gene. This is important because the mutation is actually going to be in our X, and because females have two, it's rare for them to really be affected. However, for our men, this likely will be expressed because they only have one X and one Y. Females will not exhibit this because if she has an X chromosome without the trait, it will not be expressed, but it could be carried. And examples of this would be hemophilia and colored blindness. Kind of into continued genetics, we are having trisomy 21. This is actually also called Down syndrome, where we're having 47 chromosomes rather than 46. Normally, there's only going to be 2 on trisomy 21, but this is kind of where we're having an additional one as a genetic testing to confirm this. And the reason I say confirm is because we could have testing done before to kind of take a little guess. It would not be confirmation. It could be like a screening rather. That'll be before, but at 15 to 21 weeks, we're going to have what's called the amniocentesis. It's going to, of course, be getting to our amnion. And with Down syndrome, age is actually related to the incidence of this. That's why with mothers, when it comes to their charts, things like that, we could have AMA, which is called advanced maternal age. And that was it for the slides. Now we're going to have some practice questions. I went ahead and made some more for you guys to kind of get your mind ready for what could be on the test. Right after that, we're going with our menstrual cycle. We're going to have, just give some time a little bit, because I can go and read it out. When describing the menstrual cycle to a group of young women, the nurse would explain that our estrogen levels are highest during which phase of our cycle? The answer for this is actually going to be B. The reason for this is estrogen levels are going to be high during our proliferative phase. And then progesterone is the main hormone for the, would be for C, the secretory phase. It's also important to know that our levels of estrogen and progesterone are going to drop during the ischemic phase, and of course, their fall during our menstrual cycle. Next question here. The pregnant client asks the nurse when the male and female reproductive organs begin to differentiate. The best answer for this would be, it's going to be 8 weeks. That's whenever our organs are finally getting done, okay? The nurse is teaching a middle school class about our embryonic reproductive organ development. Which statement would indicate that the student understands this? Kind of going back to our slides on getting the two together. Yes, that's correct. Girls will be born with all the ova they will ever have. Kind of a fun one right here, doing some math. If a client has a usual 28-day cycle and she ovulated on March 10th, I put this in because March 10th is my birthday. When would our client expect their next menses to begin? If you would like to take a guess, or just think it in your head, write it down. The answer for this is actually going to be, I think, A, because it's going to be 14 days after. Because remember, ovulation is about 14 days. Let's look at the rationale. Yeah. Women with a 28-day cycle, ovulation is typically around day 14. Therefore, the menses will begin 14 days later on March 24th. And this was that answer to the old one. I guess I went ahead and moved slides around when I was making it, but yep, that one was B. This one's kind of a harder problem. We didn't really go over this. Just go and take a stab at it. A school nurse is teaching a health class to our adolescent males, explaining that our spermatozoa is going to become motile and fertile during the 2 to 10 days, and they're going to be stored in. And the answer to this is actually going to be, if you want to pause if you're watching the recording. Okay, the answer is going to be A. Kind of moving on. The nurse is reviewing documentation from a student nurse. The student nurse has encountered a patient who reports that she has no pubic hair or axillary hair, and she has not experienced growth of her breasts. The student nurse asks about the physiology of this occurrence, so they're wanting to know more. The nurse should explain to the student that this indicates that they are lacking which hormone? Yes. A. Good job. Kind of going into our anatomy here. Just because as an example to kind of keep you on your toes. We didn't really go over this, but kind of good to know. The client shows an understanding of the pelvic cavity divisions by stating, and we have our 4 options here. Kind of a little different. I'll go ahead and give you guys the answer. The answer is going to be A. The true pelvis is made up of a sacrum, coccyx, and our inanimate bones. Next, as a question, we have our nurse teaching new pregnant clients that if an ovum is fertilized and implanted into the endometrium, the hormone the fertilized egg begins to secrete is. So breaking this down, yes. But breaking it down as an example, this is the pregnancy hormone, guys. This is our pregnancy test hormone, and this is that one that's really rising. throughout pregnancy. HCG. Good job. Oop. Did not mean to give you that. By what week can the fetus gender be determined? This will be 16. The nurse is explaining our menstrual cycle to a group of women. The teaching on phases of the menstrual cycle should include the fact that the corpus luteum begins to degenerate. Our hormones, estrogen and progesterone levels are going to be falling, and the blood supply to the endometrium is reduced in which phase? And these phases here, guys, really just, I wouldn't like stress out too much about it. If you can understand what we talked about on the PowerPoint slides, that'll help a lot. I don't think she would go through and, this phase is this, give me a whole example. If she did, I would definitely, I'll check with her, but this stuff, it's just good to know for your HESI, rather. Good job, D. The nurse is preparing a handout for our adolescent females on the menstrual cycle. We're talking about phases again. What term should we use for the phase in which our vascularity of our uterus is increasing and the endometrium becomes prepared for our fertilized ovum? And whenever it comes to kind of breaking this down, this is going to be actually the proliferative phase. Kind of, it's becoming prepared for this life of our ovum to kind of get started. So it's going to be with our pro-life, proliferative phase, things like that. It wouldn't be really menstrual because menstrual is kind of releasing all of that. Okay, it's getting rid of that blood because the pregnancy didn't occur. At the first prenatal visit, a woman and a nurse are discussing fetal development, and our client's saying, when will my baby actually have a heartbeat? The nurse should reply, the heartbeat of an embryo is distinguished by which week of development? The answer to this, guys, is going to be A. I think it's going to be 4. The client that has read the placenta produces hormones that are vital to the function of our fetus. And it is evident that the client understands the function of our placenta if she's stating that which hormone is primarily responsible for the maintenance of our pregnancy past the 11th week. And we hit on this a lot. That's, yes, D, progesterone, pro-pregnancy. A pregnant woman tells the midwife, I've heard that if I eat certain foods during my pregnancy, the baby will be a boy, right? The nurse's midwife responds and should explain that this is a myth and that the sex of the baby is actually determined at the time of fertilization. This will be B. Reason for this, remember we're having, it's either going to be XY or XX. So that's kind of why, okay? We have a pregnant client who is at 14 weeks gestation and is asking her nurse why the doctor used to call her baby an embryo and is now calling it a fetus. What is the best answer to this question for our patient? Actually, I think you might be right. I think it could be A and C, but I have to look into it. Because I think it's A, that the fetus is the term. But it would make sense that the embryo goes from our conception until the 8th week. But I guess the reason for that it's A is because our client's 14 weeks and she's wanting to know why it's called the fetus. So I guess it's just kind of how you word it. Our client's telling our mother that her mom was a twin, 2 of her sisters have twins, and several cousins either are twins or gave birth to twins. This client too is expecting twins. Because there is a genetic predisposition to twins in her family, there is a good chance that the client will have this will be right here, actually A, dizygotic. Remember, we're having 2 of everything, the 2 placentas, 2 ovum, things like that. Really just to kind of break that stuff down and the key differences. When it comes to fraternal twins, that can be genetically passed down. Identical twins is not passed down. So that's kind of what that term would be. As a true and false question, the umbilical vein carries oxygenated blood to the fetus. Is this true or false? And remember, guys and girlies, this is going to be opposite of what you would usually think. So the answer for this would be true, that our umbilical vein carries oxygenated blood to the fetus. Kind of a easier question here. Which altered chromosome causes a child to be born with Down syndrome? The answer for this would be C, because remember, we also call it trisomy 21. This is a really good question because I promise you there will be things that really go inside with this stuff. By which week are all of our organs formed? This is going to be 8. Okay. Yes, good job, good job. This one is kind of a harder question right here. This is going to be kind of an order question. A nurse is explaining to a client about our monthly hormonal changes, starting with day 1 of the menstrual cycle. If you could put all the 4 hormones in the order of which they elevate during the menstrual cycle. I'll go ahead and give you guys an answer right here. So you can kind of really read it to yourself right here. We're going to have 2, 1, 3, 4. But to really break it down, for 2, the gonadotropin releasing hormone is stimulating our production of our follicle stimulating hormone. I think I might have said that wrong. The G hormone is going to be stimulating our FSH hormone, and then our luteinizing hormone. So that's why 3 would be after 1. Our FSH levels rise first, and our LH is going to follow that. And then after ovulation, our progesterone levels are going to rise. Because remember, guys, after ovulation, our body's getting ready to go ahead and become pregnant. Alrighty. A woman's temperature has just risen 0.4 degrees, often can go up to 1 as well, and will remain elevated during the remainder of her cycle. She expects to menstruate in about 2 weeks. What hormone is responsible for this change? Really breaking it down, this would be signaling ovulation, and the hormone of this is actually going to be not 4, but it'd be 2. It would be progesterone. Remember, guys, our body is getting ready to menstruate in about 2 weeks. So kind of really just kind of breaking it down off that slide. Um, from 2 weeks from now is going to be menstruation. So we're actually at ovulation right now, and ovulation is being marked with progesterone. Okay, kind of as a little thing we have written here. Progesterone levels will, after ovulation, will elevate and spike about 5 to 6 days after ovulation itself. So it's going up, it's going up, it's going to spike. These levels are thermogenic, therefore heat producing. That's why we could have that temperature kind of go up a little bit. This is the reason our temperature could increase following ovulation. It's kind of really cool. I'm curious to, see the temperatures. I mean, I feel like it's just really cool to kind of learn about. And I think Harold one time even told us in class, she was like, if you really wanted to, if you're ovulating, you take a temperature, kind of compare. All righty. Next question here. The nurse is creating a pedigree from a client's family history. Which of the following symbols should the nurse use to represent a female? I didn't go over this. I think this one would have been an yes, circle. Nice. Love it. Let's go. The circle is used to represent our females. Our genetic counselor is informing a couple they have a 25% probability of getting pregnant with a child with a severe genetic disease. The couple asks the nurse exactly what that means. Which of the following responses by the nurse is appropriate? I think you easily probably could get this question correct by putting 4 right away, because with our word choices here, we have will, and I feel like will isn't a really good strong word to say to our patient here, because then that's just not really going on there. The answer for this is 4. This is true because every time a woman gets pregnant, there actually is a 25% chance that she is carrying a child with the disease. And it's just more important for you to say that may be what's going on there. This is a good question. I typed it out for you guys. The nurse is teaching a couple about X-linked disorders because they're concerned they might pass on hemophilia to their children. Which response indicates a need for further teaching? So using our nursing skills here, which one is kind of false? I'll give you guys some time. Yes, correct. Yay. Going on here. If the father doesn't have it, then his kids won't either. I don't want to get you guys confused with anything. I did type up the rationale that I found, and I'm going to read it to you guys. Males are more affected than females. A male only has one X chromosome, and all the genes on his X chromosome will be expressed, whereas a female will usually need both X chromosomes to carry this disease. There is no male-to-male transmission, since if there is no X chromosome from the male, it's transmitted to the male offspring. But any man who is affected will have carrier daughters. If a woman is a carrier, then there's a 50% chance that her sons will be affected and a 50% chance that her daughters will be carriers. And that's it for our PowerPoint. I'm going to go ahead and stop the recording.